You know that searing, debilitating pain that shoots down your leg? Well, for most of us, our first thought is probably sciatica, and we assume the problem is a slipped disc in our back. But it turns out that for a surprising number of people, the real story, the actual source of the pain, is hidden somewhere else entirely. So, what if the culprit for that intense leg pain isn't your spine at all? What if it's happening much deeper, in a place most people would never suspect? The buttock itself. And this is where it gets so frustrating, right? You're in absolute agony, you go through the standard spinal MRI, and the report comes back clean. Or maybe it shows a few minor things that just don't explain how much pain you're in. This is that medical mystery that leaves countless patients and doctors just searching for answers. Okay, so if the problem isn't in the spine, where do we look? Well, the answer lies in this really complex area called the deep gluteal space. Let's dive in and take a closer look at what's going on in there. So here it is, the official name, deep gluteal syndrome, or DGS. Now let's just unpack that for a second. Non-discogenic simply means it's not caused by a spinal disc. Extrapelvic means it's happening outside the main pelvic bone structure. And entrapment, well, that's the key. It means your sciatic nerve is literally being pinched or squeezed or trapped by the tissues around it in your buttock. And this right here is probably the single biggest clue that separates these two conditions. You see, traditional sciatica often gets worse with movements that tweak your spine, like bending or twisting. But DGS, its classic calling card is that it gets way worse when you're sitting, sometimes after just 20 minutes. That sitting puts direct pressure right on the trapped nerve. For a doctor, that's a huge clinical clue. Now, the term DGS is kind of like an umbrella diagnosis that covers a bunch of potential issues. For the longest time, everyone focused on just one thing, piriformis syndrome, where the piriformis muscle was blamed for everything. But we now know the sciatic nerve has to navigate this busy intersection of muscles and tendons, and any one of them can cause a major traffic jam for the nerve. And this, folks, is a real game changer. It turns out the most common culprit in DGS isn't even the piriformis muscle itself, but something called fibrous bands. Just think of them as little bits of internal scar tissue. Maybe they formed after a fall you took years ago, and now they're stuck to the sciatic nerve, basically tying it down. The way this gets described is just brilliant. See, your sciatic nerve isn't supposed to be stuck in one place. It needs to glide and stretch, up to 28 millimeters, believe it or not, every time you move your hip and leg. But these fibrous bands, they can act like a seatbelt, squeezing the nerve, or a leash, yanking on it, or even a splatter of glue just holding it in place. You can imagine how any of those would cause some serious pain when you try to move. So how on earth do you find a problem that's basically invisible on a standard MRI scan? Well, it takes some real diagnostic detective work. The path to getting a DGS diagnosis isn't just one single test. It's this careful, multi-stage process. It's all about systematically ruling things out, then doing some very specific physical tests, then using more advanced imaging, and finally, confirming the source with pinpoint accuracy. First things first, you gotta rule out the obvious. But here's the trap so many people fall into. We know from studies that a whole lot of people with zero back pain have disc bulges or other little issues that show up on their MRIs. A doctor might see that, stop looking, and completely misdiagnose the problem. And that means the real cause, the DGS, is left untreated. And this is exactly why specialized imaging is so critical. A standard MRI is only about 66% specific for spotting something like piriformis syndrome. But a magnetic resonance neurography, or MRN, which is literally designed to get a good look at your nerves, its specificity jumps all the way up to 93%. It can actually make that irritated, trapped sciatic nerve light up, giving a crystal clear visual clue that that's where the problem is. And then we have the final piece of the puzzle. This is the gold standard. To be absolutely certain, doctors can use an ultrasound to guide a needle right to the suspected spot and inject a local anesthetic. If the pain just disappears while that anesthetic is working, that's the smoking gun. You've found the source. So once the mystery is finally solved, the next question is pretty obvious. What can we do about it? Well, the good news is there are some very clear paths to getting relief. Now, first, it's really important to set some realistic expectations. Conservative therapy is always where you start. But because DGS is a mechanical problem, that nerve is physically stuck, things like stretching and physical therapy alone, well, they fail for up to half of all patients. So you've basically got two main pathways here. The conservative route involves trying to calm everything down with physical therapy, activity changes, and maybe some targeted injections like steroids or even Botox. But when that doesn't work, the definitive solution is a minimally invasive endoscopic surgery where a surgeon can go in and physically release the nerve from whatever is trapping it. And the results from that surgery can be absolutely life-changing. I mean, look at this. In a 2-year follow-up, 90% of patients had their pain improve, and 86% got their strength back. These are just fantastic outcomes for people who have often been suffering for years and years. And get this, on top of being super effective, this minimally invasive approach is also incredibly safe. We're talking about a minor complication rate of just 1%. Major complications are basically unheard of. It's a really high-reward, low-risk procedure. So let's zoom out for a second. Why is all of this so important? Well, because understanding deep gluteal syndrome is really a fundamental shift in how we think about a very common and very disabling type of pain. You know, our understanding of this didn't happen overnight. It started way back in the 40s with a super narrow focus on just the piriformis muscle. But the real breakthroughs, they're much more recent. Advanced imaging in the 2000s, and then these new surgical techniques that let doctors actually see the problem for the very first time. And all of that led to the much broader, much more accurate diagnosis of DGS in 2015. And if you want to understand the real-world human cost of this diagnostic puzzle, just listen to this statistic. It's absolutely staggering. One of the pioneering doctors in this field said his patients saw an average of 8.5 different specialists before the correct diagnosis was finally made. Just think about the years of pain and frustration that number represents. So, at the end of the day, DGS is this powerful reminder for both patients and for doctors. When a common diagnosis just doesn't quite fit or the tests aren't matching up with the symptoms, it's time to look beyond the obvious. It's time to investigate those less traveled anatomical roads. And that really leaves us with one final big question to think about. The story of deep gluteal syndrome, this misunderstood condition that was finally figured out because of new technology and a new way of thinking, it really makes you wonder, right? What other conditions, what other sources of chronic pain that we currently write off as unexplained are just waiting for their own closer look?